All right, welcome everyone to our fortnightly Q&A session with Dr. Wong every Wednesday evening, 9 p.m. Central or 10 p.m. Eastern if you're in New York or Boston area. If you're in Australia, it's Thursdays at 12 p.m. lunchtime with Dr. Wong Q&A session open to all dentists, but we obviously prioritize our mentoring students, our advanced students who have questions. Every 2 weeks, we change the Zoom link. You just simply go to straighttnaturally.com/Zoom, and it will redirect you to this page here, and you click on register now. And then the Zoom link is updated every couple of weeks. So I'm just going to put that in the chat box in case you need to save this somewhere. In 2 weeks' time, we should have another session, but the following day, tomorrow, we'll end up updating the Zoom link as it's unique every 2 weeks, obviously. Tonight, we've already had 2 sessions where we've covered the Texas A&M study from Texas A&M on the early effects of early bi-block treatment on hyperdivergent children. If you haven't received the paper, it's available for download, as you can see. There's no opt-in required. I'll just give the link to everyone. That's the YouTube recordings from 2 sessions ago. About a month ago, we had our 50-minute webinar where Simon, Dr. Wong, my brother, went over the findings of this 80-page research paper over like a 10-15-year period, 150 consecutively treated cases, of which roughly 1/3 were hyperdivergent. And you can watch this at your leisure. People have asked, where do I find previous Q&A sessions? When you go to our YouTube channel, you will... Actually, my brother is calling. Let's see if he needs to be let in. Oh, do I need to let you in? Oh, yes, I probably do. Second. I think he must be as an attendee now. Oh, there he is. Promote to panelist. Okay, so Simon's now joining. So if you are wondering where our fortnightly Q&A session recordings are, they're here, right down the bottom. If you go to our YouTube channel at Dr. Wong Simon, you will be able to access all the fortnightly recordings of our Q&A sessions. If you can submit questions in advance, as some of you have tonight. So we'll be going over these questions, and there you go. So this is, if you're brand new and haven't been exposed to postural orthodontics, we have a free mini course. There's over 7 hours. I've lost count, 10-15 hours of our 2-day course is uploaded here. Basically, most of the 2-day course. We don't include specific detailed protocols that are part of the 2-day paid course, obviously, but you can get a very good sense of what this is all about and make a decision if this is for you or not. But without further ado, Simon, over to you. Do you want to just go through the questions?
Hi, you have to let me share.
I think you are able to share now. All right, if you have questions, you can submit them in the Q&A box, and we'll try to get through to as many as we can, but there's been a lot of questions submitted already. So these, I'm sure, will be of interest to everyone. I'll pass it over to Simon. Thanks.
Okay, so we've got some questions for this week, which we'll go through. So, good morning. I was going through the recent June introduction class, and on the first day in the exam section, you mentioned that below tone muscle children, we will be chasing class 2. Can you help me understand? So, children with low tone hang their mouth open. And the more you hang your mouth open, the more class 2 you become. So if you bite your teeth together now, your teeth sock in to some form of occlusion. When you open your mouth, your lower molar and canine moves down and back away from the maxillary teeth. That change in the rotation of the mandible makes the mandible more class 2. When you hang your mouth open, you hold your jaw in a class 2 relationship relative to the upper. And as the upper teeth erupt to try to chase and catch the mandible, you end up with teeth that are socking in into a more class 2 relationship. But because you're hanging your mouth open, you keep hanging your mouth open, and the class 2 continues to worsen. Which ties into the second question, which is when you treat a child with an appliance, I understand that will be adding vertical. You mentioned that adding vertical will create more class 2, so that's the same answer. When you hang your mouth open, you increase vertical and you retrude the lower jaw. So yeah, end up with increased vertical and more class 2. So that's really the secret to correcting malocclusions. If you keep teeth softly together, mouth fully closed, then you hold that position. If you've done it all your life, that position will have very even relationship of upper and lower jaw, and you'll end up as a class 1. Next question, if you quote, say 6,200 for a phase 1 postural orthodontic case, and you end up needing to bracket the 6 front teeth to tidy up, do you charge an additional 1,000 or 2,000 on top of the original fee? So do you have this specified in your informed consent? So generally, you have to make a decision about how you treatment plan and how you provide your consent forms. So in my practice, I try to be as transparent and as detailed as possible. So if I anticipate we're going to need to do bracketing to tidy up teeth, I mention this and I give costs for it. If I'm surprised and I did not anticipate this, but I have to do this to finish, then generally I eat the costs because that's my error. It's like most things in life, you take your x-rays, take your photos, do your treatment plan, and you tell someone that they need 2 crowns, and you quote them for 2 crowns. If you start the treatment and then realize, oh, they actually need 2 crowns and 2 fillings, what are you going to do? You can either eat the costs or you can tell them it's 2 extra fillings, and they will leave the practice. They'll probably pay for the crowns and the fillings, but they'll badmouth you to the rest of the universe, saying that, well, he quoted me and then he upsold and added on extras. You just have to make a decision about how you practice and whether you want to surprise patients once you've started their treatment, or if you want to be upfront about it from the beginning. Okay. 4, I read your informed consent form in the documents downloaded, and I changed the wording from orthotropics to postural orthodontics. Do you have a separate form for postural orthodontics, and what other forms do you hand out to parents? Informed consent, GoFX, the weekly exercise sheets. Yeah. So, they're just templates. They're my practice templates. Adjust them to suit your needs. I do both orthotropics and postural orthodontics, but obviously that's not appropriate for you. And you've got to make you've got to customize the forms to your own practice. And all the handouts that you have, I use for my patients, yes. 5, when you are considering starting a postural orthodontic case and you want to test them on the 30-day challenge, how much do you charge for your time and effort for this first several months following up with them? I love your idea of having parents video them every day and send to me to review. This is a great way to test their level of commitment, but this takes time and energy. I know that parents will listen more if I instruct them and respond to videos, etc. As you mentioned, you could take up to 6 months for them to get through this 30-day challenge. So the 30-day challenge is part of the process. All right, so that's kind of incorporated within the fee structure of the treatment planning. If I am going to use the 30-day challenge to get a sense of whether I want to take these patients on, I don't charge them for it. I just tell them, when you've completed 30 consecutive days, come back to me. So it's an onus on them to do this and not for me to supervise them. I'm trying to get a sense of if they understood what I talked about, if they are on the same page as me, if they have the commitment to do a relatively simple and straightforward process. So I leave it to them. I don't charge. I just tell them, when you've completed 30 days, you can come back and we can talk about whether we're going to go ahead with your treatment or not. I only supervise and manage this process if we have agreed that we're going to treat and they're going to pay for that treatment in the treatment planning and the uptake of treatment. 6, turning key on your appliance is half a turn, which we consider to be 1/8 of a total 360-degree turn. And if we get 0.8 mils in 8 days, then we are getting 0.1 mil per day. Yes. And for the lower, I'm still confused on the numbers, so if I end up wanting it back, I don't have this very clear in my head, I will get lost. So the lowest screw is a 0.35 mil screw. The upper screw is a 0.8 mil screw. Again, we're turning 45 degrees, so 1/8 of the total revolution of that screw. Normally, these screws are set up for a 90-degree turn, so a quarter turn. A quarter of the full revolution, which is a full turn. So these screws are rotated normally 90 degrees, so it takes 4 days to complete a full revolution. The upper screws are large screws and they open up 0.8 mils. And the lower screws are small screws and they open up 0.35 mil. So it's just a matter of kind of doing the maths. But it's the same degree of rotation. We're doing 45 degrees. 1/8 of the total rotation, or half a turn for both upper and for lower. We do this so that it's not confusing for the clinician or the parents. I've specifically used screws that have a different amount of expansion with the given rotation. 7, I was taught elsewhere that as we expand the palate bolt flattens and we need to adjust the acrylic. Intaglio acrylic. Is this a common adjustment with your Muse stage 1? I used to relieve the palatal vault acrylic because that was my understanding as well. I don't do it now because it doesn't seem to make any difference. You know, everyone is under the impression the palate drops and that's how it flattens. From my experience, the palate just widens without dropping because the palate midline is actually anchored to the septum and it only drops as much as the septum grows. So, you know, it's a join that we're not breaking in our semi-rapid expansion. With that, to answer the question, I don't relieve the acrylic on the palate, just expand. 8, at the initial delivery, how much space is there for the screw between the acrylic shelves? Is it always the same? One always needs to account for this initial starting space and winding back, or are we just winding back until the screw no longer turns? Yeah. So the screws are all set to 0. And the cut between the acrylic is, you know, barely 0.5 mil. Just enough for the saw to cut through. So 0, the acrylic almost touches on each side with maybe a 0.5 mil gap, and the screw is set at 0. 9, for the catenary wires, are you aiming to have them on the palatal tissue near the gingival margins of the incisors or on the teeth themselves? I've noticed in mentoring videos, they appear to mostly be on the gingival quarter of the teeth and sometimes more incisal than this. Also, are these wires placed in the same spot for advancement versus intrusion forces? So the cat wires are not soft tissue borne, they're hard tissue borne, so they're the teeth bearing wires. What we want is to put them in the gingival third region. So that's ideally what we're aiming for. Having the wires touch the lingual surface or palatal surface of the incisors at roughly the gingival third, not really impinging on the gingival tissue, but sometimes it does kind of graze onto them. That's not the goal, not the aim. With the advancement or tipping versus intrusion, we're aiming for the same spot, trying to get the wire engaged at roughly the gingival third without putting much pressure on the soft tissue, mostly loading the tooth area itself. The difference is you're either moving sagittally, the wires, or you're intruding, so moving vertically the wires that will affect whether it's tipping or I mean, both instances you end up with tipping, but you do get intrusion of the incisors if you load more vertically. 10. Can you tell us what problems you face with the Myobrace system? I started with it. Results are very unpredictable. Perhaps Myobrace works well in the hands of clinicians who have strict protocols and follow the system itself. My experience was that it works well in children who rest with their teeth together. But doesn't work so well when children don't rest with their teeth together. I think when I was trained from Myobrace, there was I think BWS wire, there's the expanding wire, which you bracket this, no, you band up the sixes, and then you have like a TPA wire, which we expand and engage into the slots, and that would initially create arch development. And then we would follow up with the various Myobraces with the softer materials to begin with, and then move up the scale with the reinforced materials. It would be incorporating the exercise program. It was originally 1 or 2 hours during the day wearing the Myobrace, the exercises, and then sleeping at night time with the Myobrace. The program is designed from when I was trained in it. The children were to be taught in a group setting, and that was to help give them that peer pressure to do the exercises. And I just found personally that I struggled to get consistent results, and very often the incisors would retrocline from the lip pressure and the lack of elevator muscle engaging the incisors fully into the Myobrace system. So instead of biting into the Myobrace, the children would just hold their lips together, and that would force the incisors against the front of the Myobrace. But because their teeth were still apart, it would end up retracting the upper incisors, then creating, again, that class 2 chasing relationship. I'm sure those aspects can be overcome, but I like the system that I have now because I've been able to customize the appliances, and I've been able to be very successful and with predictable outcomes. When I was taught the Myobrace system, they did use the Mu Stage 1 5 block, which is very similar to what we're using now. So, lots of things I found to be good and lots of things I've struggled with, and you just find a setup that works for you. The most important thing is you just need to have something that works consistently well. Whatever it is, if you find that that system works and gives you consistent, reproducible, favorable outcomes, then use it. So I'm not discouraging you guys from using any systems out there, but it's very important that you follow the guidelines and the instructions of whatever system you're using as closely as possible, because whoever created a system usually has found it to be consistently successful, but only if you follow the protocol. And it's like my system. If you don't follow my protocols, you won't get my results. Next question is, what do you mean by ease cartwheeling? So one of the issues with removable appliances is that if they're not removed using the protocol of fingers and thumbs to release the clasps or to engage the clasps in the removal or insert process, the appliance will have adverse effects on the teeth. So the appliances are designed to be inserted and removed with your hands, fingers, and thumbs in a seesaw action. So usually left to right, so that we swing the plate from one tooth across to the other tooth, so that the path of insert and removal are very slightly different, so that we can get good retention and once the appliance is in, having two different paths from insert to removal allows you that retention. Children being children shortcut this process, and instead of using their fingers and thumbs, they often will flick the plate out with their tongue. And in the insert process, will just toss the plate in their mouth, use their tongue to locate the position roughly, and then bite their teeth together to crunch the clasps into place vertically, instead of in a seesaw action, left to right. When they do that shortcut of crunching it in vertically, the clasps end up intruding the teeth, because that's the action of forcing the plate into place. Usually that kind of intrusion force is a little bit asymmetric, as it loads the distal more than it loads the mesial of the appliance, because you're biting your molars together. So you end up with the ease slightly submerging at the distal marginal ridge. And we just describe that as cartwheeling, where the distal margin ends up being more gingival than the mesial margin. So that's called cartwheeling. It's an outcome of children not following your protocols of inserting with fingers and thumbs, left to right, rather than being lazy and flicking with their tongue and crunching at home by biting their molars together. All right, so next question. What is your opinion about using twin block appliances for severe class 2 cases? So personally, I've never used a twin block appliance. It's standard of care in most orthodontic societies around the world. It's one of the accepted appliances for managing class 2 relationships. The research on twin block has been that it's very effective in reducing dental class 2 relationships in low angle cases. So, but it has no researched, verified skeletal change for any form of skeletal malocclusion. So the effects are purely dental alveolar with no verified skeletal change. So this was part of a big push in the early 2000s to make a skeletal change, and the appliance of choice for the research done by Prophet and O'Brien, Prophet in the US and O'Brien in the UK, and they did big multi-centered randomized controlled trials, and they verified that there was no skeletal improvement in Angles classification, and they also evaluated twin block as a phase 1 component of treatment, coupled with the fixed braces in phase 2 during the teenage years, and they found that the outcomes were no different to if they just waited until the teenage years and put fixed braces on. Twin block is probably the most commonly used in the United Kingdom, where it was invented. But it was universally very, very popular and is still used throughout the world today to reduce the dental class 2 issues. In my practice, when I have severe class 2, I treat using orthotropics, so I don't use the twin block appliance, but if you use twin block, then be reassured that it is an appliance that is considered standard of care, but it's a treatment that must be clarified in that it's a dental alveolar appliance, and it has little favorable impact in the long-term skeletal relationship. 13, how do you typically manage PEG microdonic laterals in phase 1 treatment plan? So PEG laterals are quite an aesthetic concern for most people. They also have a higher risk where the permanent canines mistake them for primary incisors and resorb the roots. So whenever you see PEG laterals, then we have to be mindful of those two aspects of treatment planning, and advise the parents of this particular problem. So as far as how do we protect the teeth from being resolved by the canine, the most important thing is to provide room for the canine to come through in its appropriate position. Very few children today, unfortunately, have really good occlusions with good spacing. So the arch development, the space development will make a big difference. We use approximating wires to bring those laterals more towards the midline, and we don't let them drift into the path of the canines. Occasionally, we talk about aesthetic management post phase 1 by building up using bonding, for example. But that's a discussion to be left to the parents' regular general dental provider. We often will set up the lateral to be in the position where we can build up, usually we space it so that there's a little bit of, we don't completely close the space, so that the space can be built up with an artificial addition to the crown form. But we bear in mind that if we aren't careful with the spacing, then we can end up leaving the root in the line of the permanent canine and then running the risk that the canine can damage the lateral incisor. So yeah, it can be a problem, big problem. Many surprising high number of children also have missing laterals, so that's very difficult to manage. You have to have a long discussion with the parents to figure out if you're going to aim for canine substitution or whether you're going to maintain the space so that some form of restorative replacement can be added into the future. There's a lot of complex planning involved in these scenarios because these are young children, and any replacement tooth restorations have to last 90 years sometimes. So there's a lot of long-term maintenance issues and management. Implant technology has improved leaps and bounds, but we can't place implants in children, teens, or even young adults. Often the implant specialists don't like placing implants until late 20s, early 30s. So got to be mindful of why orthodontists are so in favor of canine substitution, because the restorative long-term planning is a lot kinder to the patient. Sometimes you do end up with other compromises, such as a collapsed arch, smaller dimensions. So everything's a juggle when you have a compromise of very small or missing lateral incisors. When reviewing a cone beam CT scan, you often mention tongue position, filling their entire mouth as a bad thing. Can you describe when tongue to the roof of the mouth is not good? Tongue up brings it forward and opens the airway, correct? I know tongue down off palate is bad. There might be some misunderstanding. I've never mentioned a tongue position that is tongue to the palate as being a bad thing, because that's our ultimate goal. Perhaps we have scenarios where the oral architecture is retruded or small, and when the mouth is fully closed in a situation where the jaws are too far down and back, you end up with a reduced pharyngeal airway because the tongue eats up. The entire mouth has nowhere to go and is shoved distally and reduces the oral pharynx airway. So very often children who have significant malocclusion can't rest with their mouth fully closed because their tongue not only eats up all the oral space, but it eats up too much of the pharyngeal space and compromises their airway. Perhaps that's what I was trying to, or that's what I'm trying to explain. I'm certainly not saying that filling the entire mouth with your tongue is a bad thing. What I'm saying is some children can't keep their mouth closed because their tongue fills up their entire mouth and eats up too much of their throat for it to be a viable resting position. Next question. I have heard somewhere that we should never put a lower lingual holding appliance in a growing child. Does this hold back mandibular growth? So traditionally, a lower lingual holding appliance is anchored off the 6-year-old molars and runs a lingual path along and including right up to the incisors. So it's a U-shaped appliance that is welded or attached to usually bands of the 6s. So it's a fixed appliance. And it basically stops leeway space from closing. Right? So it doesn't allow the 6s to drift forward in a mesial drift when the second primary molars, the E's, are lost through exfoliation and changeover. So normally what happens is the 6s hold a set position from after they erupt until the lower E's are lost at around 12 years of age. At that point, because there is a size discrepancy between the E, D, C and the 5, 4, and 3, the primary second molar, first molar, and canine, the arch dimension is greater than the width of the second permanent premolar, first permanent premolar, and lower permanent canine combined. That discrepancy allows for the 5 and the 4 and the 3 to kind of find their place in the world. And the excess space is eaten up by the 6s moving forward when the second permanent molars erupt. So the only time that we don't want a lower lingual holding appliance in a growing child to be placed is at that turnover period where leeway space is meant to close so that the second molars can erupt. So if you put a lower lingual appliance in a biologically growing 12-year-old, then you hold space excessively and you block out the second molars from erupting. Does this hold back mandibular growth? Well, it holds back the natural progression of dental development and whatever associated growth that entails. 16. When you are using limited braces to tidy up the front teeth, would you recommend lingual cat wires every time? Like when upper anteriors are flared, you say that the upper cat wire is optional. What about when you put the limited braces? Don't you need the cat wires to prevent over retraction of the upper anteriors? So yeah, we use wires in the back, like a lingual lower lingual holding appliance. You can use the cat wires on the upper to maintain your arch form. If you want the uppers to be retracted back, then you don't have cat wires. If you don't want them to be retracted back past a certain point, then you have them in place. So everything is used according to everything is used according to your goals. Right, so that's my input for today. I have 12 minutes of my lunch left, so I'm gonna get something to eat. Excellent, guys. Thanks for contributions, and I hope I was able to answer some of your questions.
All right, thanks, Simon. Until next time. So I'll let you go. So for those who've joined us a little bit late, we have these complimentary Q&A sessions every 2 weeks. You can register for them. Let me just see if I can, on this link here. Actually, we've made it a little bit easier. It's /Zoom. Let's see. Just paste it in the chat here. All right, so you want to save this link, and you can see the we'll tonight or tomorrow we'll update this. Date will be, I guess, in 2 weeks' time, as per usual, unless there's an emergency or we know there's something that clashes with it. And the registration link, the red button, will be updated. I see right now it's still suggesting you can join us tonight. Obviously, that will end as soon as this webinar ends. So we'll update the link. So give us a day or so to update all this, and you can come back and register for our next Q&A session. So straight to natural.com/Zoom. For those who wanted the presentation about the Texas A&M paper, it was 2 weeks ago, and we had it recorded. As you can see here, if you go to our YouTube channel, we upload all the recordings of these sessions as well, generally within 24 hours. And right down the bottom, you'll see the Q&A webinars, and the main one with the Texas A&M is July 16th. And you can actually download the paper here in the description. There we had more questions and answers the previous session. So if you want to hear the questions asked and answered by Dr. Wong regarding this paper, you can watch the previous session, which was 2 weeks ago, July 30th. What else? Quick plug for our next event. Our 7th 2-day intro is coming up Friday, Saturday, November 7th and 8th. US time zone. It's starting around 2, I think it's 3 o'clock Eastern this time, 3 to 10 p.m., 7 hours both days. We have Dr. Kevin Boyd, who'll be joining us live via Zoom. He'll have a presentation. I haven't finalized the topic yet, but we had some previous guest speakers from last year's event, and you get the recordings of that. So yes, 2:30 registration, 3 p.m. start, 10 p.m. finish. This is Eastern New York time. So over 2 days, 14 hours. Got, hundreds of pages of protocols and templates that are included. Got an early bird ending this week. Super early bird. If you're interested, $656 is a few $100 off, like 30% discount. So that is I'll give the link for those who are interested. There you go. /tickets. Yeah, if you've got questions, feel free to send us an email. info@straight teeth naturally. We obviously have advanced training and mentoring as well if you want case supervision, whether it's for your own child or your patients. That is available by application. We've got other case study vault training where you can get access to hundreds and hundreds of cases that were submitted by students over the last 5 years and archived and searchable by angles classification. So we've got a variety of advanced training to suit your needs. So the 2-day intro comes with the recordings from last year's event. So if you don't want to wait till November, you can just get the recordings only for $100 less. If you want the live stream ticket as well for the November event, you can get that. But we have the recordings from the September 2024 event, which was actually held in person in New Jersey at the Hilton. So we had that professionally recorded, and that's on demand until the end of January 2026. So you have a solid 5 months or so access, plenty of time to get through the 14 hours. 30-day money-back guarantee. You can check it all out on our website /tickets. That's about it. Got any questions? I'm Dr. Wong's brother and head of enrollment, so happy to help with any questions regarding the program, regarding the advanced training. As mentioned, we have a YouTube channel with over a dozen hours of free training that give you a good sense of what it's all about. Anyway, that's it from New York. My brother's based in Australia. I'm in New York, Eastern time, so feel free to reach out. My phone number is here. You can WhatsApp me if you're from around the world. We do have country specials. So if you're not based in the US, or if you have a team of dental hygienists or therapists who would like to join, we have very significant discounts. So to send us an email regarding that. You can check out a whole bunch of Simon's cases, 135 here that we uploaded. What else? Well, it is for early interceptive, ideally 4 to 10-year-olds, ideally 6 to 8 years of age. Just so I want to clarify, we've had people ask us about teenagers and so on, and that's unfortunately not part of what we teach for this type of early intervention. These are removable appliances and custom built. So there's different nuances in relation to postural orthodontics that I would love to share with you. On that note, I'll say good night. There's a few of you still on. If you have any questions, happy to field any questions you might have. Sorry, we couldn't answer everyone's questions tonight, but keep them. And if you're already a 2-day intro member, you can submit them in the Facebook forum. You can also rejoin in 2 weeks' time and continue your questions. We generally get through about 15 or 20 questions each session or so. So I do apologize if we can't get through any more in the 45, 50 minutes every 2 weeks. Alrighty-o. Thanks, everyone. Have a good night. Take care. We'll see you in a few weeks. Thanks, Candace. Thanks for joining us. Bye-bye.